हाय एवरीवन, वेलकम बैक टू अनदर वीडियो। ओके, सो आज हम स्नेक बाइट के ऊपर पढ़ेंगे। स्नेक बाइट क्या होता है, कैसे होता है, एंड स्नेक बाइट में कैसे कैसे मैनेजमेंट होता है। व्हाट आर द ड्रग गिवन टू द इन केस ऑफ अ पर्सन सफरिंग फ्रॉम स्नेक बाइट, एंड व्हाट आर द क्लिनिकल आउटकम। ये स्नेक बाइट के ऊपर सारा जो चीज़ है, प्रिवेंशन क्या लेना चाहिए, सब एंगल को देखेंगे। सिर्फ आज पढ़ेंगे, ठीक है। क्योंकि बहुत सारे वर्ड मुझे पता नहीं है, एंड ये जो हम स्नेक बाइट आज पढ़ेंगे वो किस बुक से पढ़ रहा हूँ। स्टैंडर्ड ट्रीटमेंट गाइडलाइन ए मैनुअल फॉर मेडिकल थेराप्यूटिक्स बाय संगीता शर्मा एंड जी आर सेठी, ठीक है। लेकिन उससे पहले थोड़ा राधा राधा कर लेते हैं। गुरु ब्रह्मा गुरु विष्णु गुरुदेव महेश्वर गुरु साक्षात परम ब्रह्म तस्मै श्री गुरवे नमः। गुरु ब्रह्मा गुरु विष्णु गुरुदेव महेश्वर गुरु साक्षात परम ब्रह्म तस्मै श्री गुरवे नमः। प्रणाम गुरुदेव भगवान शिव शंकर। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। प्रणाम प्रभु श्री गणपति। राधा 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 राधा। प्रणाम श्रीमती राधा रानी। Snake bite is an acute, life-threatening, time-limiting medical emergency, preventable public health hazard, and a neglected tropical disease. Although the total number of bites in India may be more than 5 to 6 lakhs, only less than 30% are venomous bite. Non-fatal bites may be as high as 1.4 million per years as per million death study. The poisonous snake found in India belongs to the family of Elapidae and Viperidae. The most common Indian elapids are Naja, Indian cobra, and Bungarus caeruleus, Indian crates. Among Viperidae, Daboia, Russelli or Russell viper or and Echis carinatus, saw-scaled viper are prevalent. ओके थोड़ा प्रोनाउंसिएशन शायद सही नहीं हो रहा है मेरे से, कोई बात नहीं। पेशेंट, अच्छा इससे पहले स्नेक बाइट मैंने कभी पढ़ा नहीं, शायद एक बार पढ़ा था, लेकिन आई थिंक मैंने कम पढ़ा था, ठीक है। पेशेंट कैन प्रेजेंट इन द 4 clinical syndrome or in combination, that is progressive weakness, neuroparalytic or neurotoxic, bleeding, vasculotoxic or hemotoxic, myotoxic, and painful progressive swelling. Examine the bite site and look for fang marks or any sign of a local envenomation. Fang mark or their pattern have no role to determine whether the biting species was venomous or non-venomous or amount of venom injected, severity of a systemic poisoning and nature of a poisoning, Elapidae or Viperidae venom, etc. Some species like krait may leave no bite marks. Dry bite. Snake bite are not always accompanied by the injection of a venom, मतलब dry bite. Symptom due to anxiety and sympathetic overactivity may be present. Differentiate from symptom and sign of envenomation listed in table 2.17 and figure 2.14. Redness, increased temperature, persistent bleeding, and tenderness locally. However, local swelling can be present in this patient due to tight ligature. Occult snake bite. ଦେହ ଲାଗିଲାଣି, ହେ ଭଗବାନ, ଦେହ ହାତ ପୁରା ଦରଜ ହେଲାଣି, ଥଣ୍ଡା ହେଇଯାଇଛି ସିଭିଅର ଯେ ଦେହ ହାତ ପୀଡ଼ା ହଉଛି। Occult snake bite. Krait bite victim often present in the early morning with descending paralysis with no local sign and no bite marks. Suspect in case of a snake bite victim wakes up in the midnight to 5 am in the morning with severe epigastric or umbilical pain with vomiting persisting for 3 to 4 hours and followed by typical neuroparalytic symptom within next 4 to 6 hours. There may not be any history of a snake bite. Unexplained respiratory distress in children in the presence of a bilateral ptosis or sudden onset of a acute flaccid paralysis locked in syndrome. Sometimes patient may present with throat pain, chest pain, joint pain also. The important early diagnostic criteria of a systemic viper poisoning are blood stained sputum and a non-clotting of a blood. The early sign of an elapid envenomation are ptosis and glossopharyngeal palsy. First aid measure. Shift the victim to the nearest health facility PHC with bed or hospital immediately after providing first aid to a health facility where optimal medical care with anti-snake venom is available. Close observation and definite treatment can be provided at the community or village level. Check history of a snake bite and look for obvious evidence of a bite, मतलब fang puncture, marks, local pain, bleeding, swelling of the bitten part, breathing difficulties, abdominal pain, vomiting, etc. Reassure the patient as around 70% of all snake bite are from non-venomous species and there is the treatment of a venomous snake bite. Clinical manifestation of a snake bite: neuroparalytic, progressive weakness, elapid envenomation, 6D, furrowing of a forehead, ptosis, diplopia, dys, dysarthria, dyspnea, dyspnea, dysphonia, dysphagia, diminished or absent deep tendon, reflex, and head lag. Stridor ataxia may also be seen. Associated hypertension and tachycardia. Vasculotoxic, hemotoxic, or bleeding, viperine envenomation. Local manifestation: local swelling, bleeding, blistering, and necrosis. Pain at the bite site and severe swelling leading to compartment syndrome. Tender enlargement, lymph node, systemic, visible systemic bleeding, acute abdominal tenderness, lateralizing neurological symptom, consumption, coagulopathy, painful progressive swelling, local necrosis, swollen limb, blistering at and around the bite site, skip lesion, uh, ecchymosis, significant painful swelling involving the whole limb and extending onto the trunk, compartment syndrome, regional tenderness, enlarged lymphadenopathy. मायोटॉक्सिक में क्या क्या आएगा? मसल एक, मसल स्वेलिंग, इनवॉल्यूंटरी मसल कंट्रैक्शन, पैसेज ऑफ डार्क ब्राउन यूरिन, compartment syndrome, cardiac arrhythmia, acute kidney injury due to myoglobinuria, subtle neuroparalytic sign. Now, ये हो गया clinical manifestation of a snake bite. Now, at the community और village level का third point जो होता है, immobilize the limb in the same way as a fractured limb. Splints should extend the entire length of the limb, immobilizing all of a joint of the limb in the recovery position या तो prone position on the left side with airway protected. Use bandages or cloth to hold the splint, मतलब wooden stick, but do not block the blood supply or apply pressure. Kneel by mouth till victim reaches the medical health facility. Arrange transport of a patient to medical care as quickly and passively as possible by vehicle, ambulance, toll free number 102 और 108 एक्सेट्रा. बोट हो गया, बाईसाइकिल हो गया, मोटर बाइक्स हो गया, स्ट्रेचर हो गया, एक्सेट्रा. Whichever is readily available. If ambulance is not available, motorbikes may be a feasible alternative for rural India, but third person should hold the patient sitting behind. Victim must not run or drive himself to reach a health facility. If possible, PSC medical officer should accompany the patient to inform that the doctor or referral doctor of the progress. manifestation of new symptom and facilitate resuscitation on the way. Remove shoes, rings, watches, jewelry, and tight clothing from the bitten area. Leave the blister undistributed. Important do nots. Radha Radha. Jai Shiv Shankar. Do not attempt to kill or catch the snake. Discard traditional first aid method, blackstone, scarification, and alternative medical herbal therapy. Do not wash wound and interfere with the bite wound. Incision हो गया, suction हो गया, rubbing हो गया, massage हो गया, tattooing हो गया, applying of herbs or chemicals, cryotherapy or cautery. Do not apply or inject anti-snake venom locally. Do not tie tourniquet as they may cause gangrenous limb. If victim is expected to reach the hospital in more than 30 minutes but less than 3 hours, crepe bandage may be applied by qualified medical personnel till the patient is shifted to the hospital. The bandage is wrapped over the bitten area as well as the entire limb with the limb placed in the splint. It should be capable of admitting a finger beneath it. Treatment figure 2.15. At a healthcare facility, admit all victims of a confirmed or suspected snake bite and observe for at least 24 hours for sign of envenomation. Provide first aid measure, supportive measure immediately before referring to a higher center. Administered ASB therapy as soon as there is evidence of envenomation before referring to a higher center. Refer patient presenting with neuroparalytic symptom immediately to a higher facility for intensive monitoring after giving atropine and a neostigmine इंजेक्शन एन इंजेक्शन एट्रोपिन नियोस्टिग्मिन इसको एन इंजेक्शन बोला जाता है क्रिटिकल और नॉन क्रिटिकल अराइवल assess circulation airways and breathing and deal with any life threatening symptom on presentation as below vasculotoxic patient presenting with bleeding from multiple orifices with hypotension, reduced urine output, obtunded, mentation, drowsy or confused, and cold extremities need urgent attention and ICU care for volume replacement. Pressure pressure support dialysis and infusion of blood and blood product. See the following section. Okay. Neuroparalytic patient presenting with respiratory paralysis, tachypnea and bradynia or paradoxical respiration, only moving abdomen, obtunded, mentation and peripheral skeletal muscle paralysis need urgent ventilator management with endotracheal intubation, ventilation bag or ventilator assistance. Other patients can be evaluated to decide the severity of their illness. So, establish establish large bore intravenous access and start NS slow infusion. Test for presence of a pulse distal to the tourniquet. If the pulse is absent, in case of a clinically confirmed venomous bite, remove tourniquet only in the presence of a doctor by the side of the patient after starting loading dose of anti-snake venom and keep atropine neostigmine injection ready. In case of a multiple ligature tourniquets, pressure immobilization, all the ligature can be released in emergency room except the most proximal one, which should only be released after admission, and all preparation for handling the complication and to start ASV. Sudden removal can lead to a massive surge of venom leading to neurological paralysis, leading to neurological paralysis, hypotension, etc. If the tourniquet has occluded the distal pulse, then a blood pressure cuff can be applied to reduce the pressure slowly. Carry out a medical assessment including history and physical examination and every 1 to 2 hourly and record bite side local swelling, painful tender and enlarged local lymph gland, persistent bleeding from the bite wound, blood pressure, pulse rate, bleeding, गम हो गया, नोज हो गया, वोमिट, स्टूल, यूरिन, level of consciousness, drooping eyelids and other sign of paralysis. The Glasgow Coma Scale cannot be used to assess the level of consciousness of a patient paralyzed by neurotoxic venom. Bilateral dilated poorly or non-reacting people is not a sign of a brain dead in elapid envenoming. सस्पेक्टेड स्नेक बाइट, अगर ओवर्ट बाइट होगा, हिस्ट्री ऑफ अ बाइट नॉन वेनोमस 70%, वेनोमस 30%. ऑकल्ट बाइट, नो हिस्ट्री ऑफ अ बाइट. अगर ये क्रेट बाइट हो गया तो न्यूरोपैरालिटिक सिम्टम विथ नो लोकल साइन होगा, सीवियर एब्डोमिनल पेन होगा, वोमिटिंग होगा. तो उस क्षेत्र में आपको एएसबी देना पड़ेगा, अट्रोपिन नियोस्टिग्मिन देना पड़ेगा, वेंटिलेशन करना पड़ेगा. अगर ओवर्ट बाइट होगा तो अगर ये एसिम्टोमेटिक पाया जाएगा, एंजाइटी, पाल्पिटेशन, टैकीकार्डिया, पैरेस्थेसिया, तो ऑब्जर्व फॉर 24 आवर. ठीक है, ऑब्जर्व फॉर 24 आवर. देन अगर प्रोग्रेसिव, अगर पेनफुल, अगर स्वेलिंग आ रहा है, अगर ये भाइपर के कारण हो रहा है तो लोकल नेक्रोसिस होगा, एक्कीमोसिस, ब्लिस्टरिंग, पेनफुल स्वेलिंग होगा, कंपार्टमेंट सिंड्रोम होगा. तो अगर ये सब पाया जाएगा तो एसबी स्टार्ट करना पड़ेगा. ड्राई बाइट अगर हो रहा है तो ड्राई बाइट के केस में एंजाइटी आएगा, पाल्पिटेशन आएगा, टैकीकार्डिया, पैरेस्थेसिया होगा. सिम्टोमेटिक अगर होगा तो प्री डोमिनेंट सिम्टम मैनिफेस्टेशन आपका हो जाएगा, जिसमें सिम्टोमेटिक में प्री डोमिनेंट सिम्टम मैनिफेस्टेशन होगा, मतलब प्रोग्रेसिव पेनफुल स्वेलिंग हो जाएगा, न्यूरोपैरालाइटिक होगा, भास्कुलोटॉक्सिक होगा, मायोटॉक्सिक होगा. न्यूरोपैरालाइटिक अगर होगा तो ये जनरली कोब्रा या फिर क्रेट के द्वारा होता है. तो इसमें टोसिस होता है, डिप्लोपिया होता है, डिसआर्थरिया, डिस्फोनिया, डिसनिया, डिस्फाजिया, पैरालिसिस. तो ये अगर सिम्टम आ रहा है तो एस भी स्टार्ट करना पड़ेगा, आट्रोपिन न्यूस्टिगमिन रखना पड़ेगा, पेशेंट को वेंटिलेशन देना पड़ेगा। देन अगर भास्कुलोटॉक्सिक होगा तो रसेल्स वाइपर, सॉस्केल वाइपर, ये दोनों होता है भास्कुलोटॉक्सिक के क्षेत्र में। तो इसमें ब्लीडिंग होगा, डीआईसी होगा, शॉक होगा, एक्यूट किडनी इंजरी होगा। तो इस क्षेत्र में भी एंटी स्नेक वेनम दिया जाता है, सपोर्टिव ट्रीटमेंट जो भी होता है दिया जाता है, डायलिसिस किया जाता है, ब्लड का ट्रांसफ्यूजन किया जाता है। देन अगर मायोटॉक्सिक अगर होगा, फ्लैट टेल्ड सी स्नेक मायोटॉक्सिक, तो इसमें मसल एक होता है, मसल स्वेलिंग होता है, इनवॉल्यूंटरी कॉन्ट्रैक्शन ऑफ मसल होता है, कंपार्टमेंट सिंड्रोम होता है। तो इसमें भी एस भी दिया जाता है, सपोर्टिव ट्रीटमेंट होता है एंड डायलिसिस किया जाता है। Even though present as a predominant manifestation, but there may be overlap of syndrome as well. ASB indicated in rapidly developing swelling only. ASB indicated in rapidly developing swelling only. Purely localized swelling with or without bite marks is not indication of ASB. प्योरली लोकलाइज्ड स्वेलिंग अगर हो रहा है विथ और विदाउट बाइट मार्क्स इज नॉट इंडिकेशन ऑफ एएसबी। फॉर रिएक्शन टू एंटीस्नेक वेनम डोज ऑफ फॉर रिएक्शन टू एंटीस्नेक वेनम एएसबी डोज ऑफ एड्रेनालिन 0.5 mg IM इंजेक्शन इन चिल्ड्रेन 0.01 mg per kg. Specific ASB for sea snake and a pit viper bite is not available in India. However, available ASB may have some advantages by the cross reaction. Atropine neostigmine injection, atropine 0.6 mg followed by neostigmine 1.5 mg IV start. In children, injection atropine 0.05 mg kg followed by injection neostigmine 0.04 mg kg IV. Repeat neostigmine 0.5 mg in children, 0.01 mg per kg with atropine every 30 minutes for 5 doses. Thereafter taper dose at 1 hour, 2 hour, 6 hour, 12 hour. Positive response is measured as 50% or more recovery of the ptosis in 1 hour. If no response after the third dose, stop atropine neostigmine injection. If any side effect of neostigmine overdose like bradycardia or muscle twitching appear, give repeat dose of atropine as slow IV drip, 1 ampoule in 1 bottle NS for 8 hours. For presenting clinical syndrome of snake bite, प्रोग्रेसिव वीकनेस लगेगा जिसको हम न्यूरोपैरालाइटिक कहते हैं या न्यूरोटॉक्सिक कहते हैं, ब्लीडिंग, भास्कुलोटॉक्सिक, हेमोटॉक्सिक, मायोटॉक्सिक एंड पेनफुल प्रोग्रेसिव स्वेलिंग एंड इट्स मैनेजमेंट। हे भगवान, carry out a medical assessment including history and physical examination and every 1 to 2 hourly and record bite site local swelling, painful tender and enlarged local lymph gland, persistent bleeding from the bite wound, blood pressure, pulse rate, bleeding, गम हो गया, नोज हो गया, वोमिट हो गया, स्टूल हो गया, यूरिन हो गया, and level of consciousness, drooping eyelids and other sign of paralysis. The Glasgow Coma scale cannot be used to assess the level of consciousness of a patient paralyzed by neurotoxic venom. Bilateral dilated, poorly or non-reacting people is not a sign of a brain dead. In elapid envenoming, Patient with elapid bites, especially crate bite, may present with locked-in syndrome. Locked-in syndrome, as patient is conscious but unable to communicate. Open eye, move any limb due to quadriplegia and anarthria. Patient retain vertical eye movement, facilitating non-verbal communication. Incomplete LIS locked-in syndrome, the patient suspicion the patient cannot communicate in any form. These patients can be saved with high index of suspicion by referring to a center with ventilator support. Confirmatory tests such as EEG, cerebral blood flow, nerve conduction velocities are recommended to avoid misdiagnosis of a coma or brain death. With ventilation and intensive care, spontaneous recovery after synthesis of a new neuromuscular junction and vesicle happens after few days. Duration can vary from 30 hours to 6 days. Great bite takes longer to recovery. To identify impending respiratory failure, bedside lung function test in adult, namely single breath count, number of digits counted in one exhalation, normal greater than 30, breath holding time, breath held in inspiration, normal greater than 45 seconds, ability to complete one sentence in one breath. Cry in a child, whether loud or husky, can help in identifying impending respiratory failure. Check for and monitor 20-minute whole blood clotting test every hour for the first 3 hours and every 6 hours for remaining 24 hours. Check distal pulse and monitor if there is presence of a gross swelling. The presence of a pulse does not rule out compartment syndrome. Examine snake carefully the snakes if brought and identify if possible. Take one smartphone photograph of the snake, dead or alive, if available, for confirmation by an expert. Look for life-threatening complications such as acute kidney injury, hypotension, parotid swelling, conjunctival edema, subconjunctival hemorrhage, renal failure, acute respiratory distress syndrome, leaking syndrome, and refractory shock, and manage accordingly. Non-critical arrival and critical patient after stabilization. Determine the time elapsed since the snake bite. Obtain a brief medical history, date of last tetanus immunization, use of any medication, history of allergy, etc. Investigation. Simple bedside examination. Measure limb circumference 10 cm proximally to the bite and repeat every 2 to 4 hourly. Single breath count 1001, 1002, breath holding time, and chest expansion measures, and look for dropping of upper eyelid. Keep on monitoring the patient and repeat all the above every 1 to 2 hours. Bedside test BT CT and 20 BT WBCT. 20-minute whole blood clotting test. 20-minute whole blood clotting test. Results should be written as clotted oblique non-clotted, not as positive or negative. Hmm. Place 2 ml of freshly sampled venous blood in a small glass vessel and leave undistributed for 20 minutes at ambient temperature. Gently tilt the test tube to see if the blood is still liquid. Do not shake. The patient has hypofibrinogenemia, incoagulable blood as a result of a venom-induced consumption coagulopathy. If blood clot is formed and sign and symptom of a neurotoxic envenomation present, classify as neurotoxic envenomation. If clotted but a diagnosis is not confirmed, carry out the test every 1 hour from the admission for 3 hours and then 6 hourly for 24 hours. If the test is non-clotting, repeat 6 hours after administration of a loading dose of ASP. Based on the repeat test result, a decision can be made regarding the need for additional doses of ASB. Caution: use new, clean, dry test tube only. Strictly avoid plastic tube as it interfere with the Hangman factor Hangman factor and becomes incoagulable. If there is any doubt, repeat test in duplicate, including control blood from a healthy person. If negative, the test should be carried out every 30 minutes from the admission for 3 hours and then hourly after that to ascertain if repeat dose of antivenom is indicated. Yearly clues that a patient has severe envenoming. Rapid yearly extension of a local swelling from the site of the bite in cobra bite on finger. Necrosis may start in few minutes. Yearly tender enlargement of a local lymph node indicating spread of a venom in the lymphatic system. Visible sign of a neurological impairment such as ptosis, muscular weakness, respiratory distress, or respiratory arrest. Yearly spontaneous systemic bleeding, especially bleeding from the gums, bite site, hematuria, hemoptysis, epistaxis, ecchymosis, unconsciousness either with or without respiratory arrest. Passage of a dark brown or a black color urine. The snake has been identified as a very venomous one, that is cobra हो सकता है, Russell's viper हो सकता है. Observe every case of a alleged snake bite for at least 24 hours before discharging. For pulse rate, respiratory rate, blood pressure, WBC count every hour for 3 to 4 hours, every 4 hours for remaining 48 hours, blood urea, creatinine, WBC count, urine output, urine for RBC in case of a viper bite, vomiting, diarrhea, abnormal bleed, extent of a local swelling and a necrosis, ECG, ABG analysis, BTCT, PTT to be repeat 6 hourly if abnormal. Anti-snake venom therapy. Indication: if anti-snake venom is indicated, that is sign and symptom of a systemic envenomation with or without evidence of a laboratory test, administered full dose without any delay. If anti-snake venom is indicated, that is sign and symptom of a systemic envenomation with or without evidence of a laboratory test, administered full dose without any delay. Do not give incomplete dose. Do not wait for any test report. There are no absolute contraindication to the ASP, but do not routinely administer ASP to any patient claiming to have bitten by snake without sign and symptom of envenoming. However, at the same time, do not delay or withhold ASB on the ground of a anaphylactic reaction to a deserving case. ASB not indicated in purely local swelling and a normal WBCT, even if accompanied by a bite mark from an apparently venomous snake or non-progressive swelling a number of hours old. However, rapid development of swelling involving more than half of the bitten limb in the absence of tourniquet and severe swelling after after bites on the digits, toe and finger indicates bite with envenoming requiring ASB. Anti-snake venom. Anti-snake venom is produced in both lyophilized form मतलब less rigid, cold chain and longer shelf life, and liquid form less preferable as cold chain in is crucial. Reconstitute ASP supplied in dry powder form by diluting in 10 ml of distilled water or NS. Mixing is done by swirling and not by vigorous shaking. Caution: do not use if a reconstituted solution is opaque or to any extent. हे भगवान सब बड़ पाऊनी. Total dose is diluted in 10 ml per kg. Total dose is diluted in 10 ml per kg. 0.9% saline or 5% dextrose or given as a infusion over 1 hour. The patient should be closely monitored. Dose of ASB for neuroparalytic snake bite. ASB 10 vial start as infusion over 30 minutes followed by the second dose of 10 vials after 1 hour if no improvement within the first hour. Dose of ASB for vasculotoxic snake bite. Low dose infusion therapy is as effective as high dose intermittent bolus therapy and also saves scarce ASB doses. Low dose infusion therapy 10 vials for Russell Viper, 6 vials for saw scaled viper as start as infusion over 30 minutes followed by 2 vial every 6 hours as infusion in 100 ml of NS till clotting time normalizes or for 3 days whichever is earlier. High dose intermittent bolus therapy 10 vial polyvalent ASB start over 30 minutes as infusion followed by 6 vial 6 hourly as bolus therapy till clotting time normalizes. No SB for sea snakes. Confirmed green pit viper snake bite even it with sign of envenomation as available. ASB do not contain antibodies against them. Prophylactic epinephrine adrenaline. Give prophylactic epinephrine 0.25 mg of 0.1 solution by subcutaneous injection In children, 0.005 mg per kg of 0.1% solution, except in non-hypertensive and if patient present with BP more than 140/90. In adult victim or patient with cardiovascular disease, draw epinephrine in readiness in 2 syringe before ASB is administered. Monitoring of a patient and precaution during ASB administration. Give ASB only by the IV route slowly with the physician at the bedside during the initial period to intervene immediately at the first sign of any reaction. Observe all patients carefully every 5 minutes for the first 30 minutes and then at 15 minutes for 2 hours for manifestation of a reaction. Never gives ASB by IM route and do not inject the ASB locally at the bite site. No ASB test dose or skin conjunctival hypersensitivity testing, as it has no predictive value in detecting anaphylactoid or late serum reaction. Take all aseptic precaution before starting ASB to prevent any pyrogenic reaction to ASB. At the earliest sign of an adverse reaction, suspend temporarily. For details of management of ASB reaction, see below. Maintain strict intake output chart and note color of urine to detect acute kidney injury early. Pregnant women and children, including newborn and small children, are treated in exactly the same way as other victims, including ASB dose, independent of the body weight in children, but the total volume is restricted to 5 ml per kg and given more slowly to prevent fluid overload. ASB doses in victims requiring life-saving surgery, such as intracranial bleeding before surgery, restore coagulation to avoid catastrophic bleeding, and higher initial dose of ASB up to 30 vial can be administered. Repeat dose of ASB. सो आज के लिए इतना ही. फिर मिलते हैं किसी स्टडी विथ मी ब्लॉग्स में. तब तक के लिए जय हिंद, वंदे मातरम. थैंक्स फॉर वॉचिंग. भगवान